So as
center one.
In the middle.
That's the arrow.
Yeah, so as I've been kindly introduced, so my name is Bryon, and I'm an orthopedic surgeon in the Singapore General Hospital. My subspecialty interest is in sports and reconstructive surgery, so I handle mainly hip, shoulder, as well as the knee joint. So when we look at knee articular defects, historically, a lot of our management is centered based on conservative management in terms of the medications, supplementations that we give, as well as physiotherapy. Injections in the past used to be just limited to steroids injection, but increasingly what we are now doing is actually to move towards this area of orthobiologics. And this is where we are talking about in terms of the PRP that the previous speakers have mentioned, as well as stem cells, whether it is from our own body or from others. So one of the things that we are beginning to understand is that in knee arthritis, it's no longer a pure mechanical issue, but rather a very complex mechanical inflammatory cascade, where it's mediated both by pro-inflammatory mediators as well as anti-inflammatory mediators. In the normal knee, these achieve homeostasis and they actually cope fine, but in a diseased knee, the pro-inflammatory cytokines overwhelm the anti-inflammatory, and that is believed to actually drive the inflammatory cascade in knee osteoarthritis. So therefore, the literature is actually driving towards orthobiologics, because in steroids use, all the thought is that we try to stop the inflammation, but there's no regeneration, no potential regeneration that is going on. On the other hand, when we move towards biologics, we want to create a favorable environment to allow the body to try to heal on its own. And those are the various types of orthobiologics that have been done. But the more common one that are used nowadays is the PRP and the MSCs, the mesenchymal stem cells. So I think platelet-rich plasma and what it is has been very well covered by the various professors before. But essentially what we want is that area of the buffy coat, the area of the very rich platelet area. And this is thought to be, when activated, releases growth factors that triggers a healing cascade and reduces tendon inflammation. Moving on from the PRP itself, I think several people have heard of leukocyte poor, so LP-PRP or leukocyte rich. And what happens is that we then go on to take away the white blood cells from the PRP concentrate itself, therefore forming a concentrate that is much lower in terms of the white blood cell concentration. So this distinction is actually very special to me, and we will go on to explore why is this so. So safety profile of PRP, in the past, there used to be a lot of concerns about whether this can be cancer causing, but I think in the literature, safe to say there is no reported case of a cancer transmission due to PRP treatment itself. It is also autologous, taken from the patient himself, so the side effect profile is much more tolerable compared to, for example, even steroids, which has many other side effects associated. So does PRP actually work for OA knee? In this study, it's a level 1 prospective, double-blinded, randomized control trial, 156 knees, and they actually saw that a single dose of white blood cell filtered PRP, which is the leukocyte poor or the LPRP, is effective in elevating symptoms in early OA knee. I think we might remember early on in the earlier presentations of the tree, and I think in early osteoarthritis, definitely we want to keep the tree going, and the nourishment actually does appear to work. These results, however, deteriorate after 6 months. So whether it is a true cure or whether or not it's just a temporizing solution still remains to be seen. However, on the other end, there's also another randomized control study, level 1 as well, 120 patients where we look at the PRP versus just a hyaluronic acid itself. And what we saw through this study is that the PRP actually has better clinical outcome especially in early arthritis. Also in this study, similar findings as well, trend favorable for the PRP group, especially for early arthritis as well. So this is a paper that actually looks at just PRP alone, or whether the bone marrow concentrate, or what we the BMSCs as we talk about. And they find that in general, patients with autobiologic tend to do favorably compared to patients who are only given hyaluronic acid. When we look at, however, the guidelines, because sometimes the guidelines can move a little bit slower than the results itself, and PRP is still an area with growing evidences. So what happens is that there's still many conditions out there that only has a reliable clinical evidence to use PRP. And one of the things that is identified is that when we actually look at all the formulations of common PRP solutions, be it for Biomed, Arthrex, or MyTech, in fact, actually the type of PRP that is used is not even standardized. The amount of blood that is taken, as well as the centrifuge settings, are very different. And this results in a product that is very muddy. There are a lot of brands out there, and each brand is saying that we are the best. However, at the end of the day, because it is so different, it's very hard to have a trial that compares them meaningfully. So some of the authors also felt that there is an issue about how much platelet is enough, and also whether or not the white blood cells, are they really beneficial or are they harmful? Because do we actually want the inflammatory effect? So this is what leukocyte-rich PRP does in tendinitis. Basically, in the early phases of tendinitis, the thought is that it's actually an aberrant healing of the tendon. The tendon tries to heal itself, but it does not heal well, and therefore this sets up a chronic tendinopathy kind of picture. So the idea is that in that case, actually some leukocyte is preferable because the leukocyte actually kickstarts the whole cleaning up process of the tendon, thereby allowing the tendon to restart its healing process. So when we look at leukocyte-rich versus leukocyte-poor, however, for knee arthritis, some of the results say that the presence of leukocytes did not affect the clinical results, even though leukocytes are thought to drive inflammatory, which is not what we want in osteoarthritis. So there appears to be no conclusive studies, and my personal opinion is that in terms of tendinopathy, a leukocyte-rich PRP tends to favor it, and that's because we know that the tendons do not heal well. We want the PRP to help to clear the tendons of debris and to kickstart the new process again. However, in knee osteoarthritis, the evidence is a bit conflicting, but it actually sits well with me that I actually want a product that do not increase the amount of inflammation in the knee. And therefore, in those cases, it is perhaps preferable to consider the use of a leukocyte-poor PRP. So moving forward from PRP, I think some of the earlier presenters have spoken about stem cells as well. So it is very critical to remember that not all harvest sites are equal. When we look at the studies, the iliac crest has the most, followed by the proximal and humerus, as well as the distal femur. But many other sites of bone do not actually give a good amount of stem cells as what we believe. Critically, sometimes we take from the calcaneum, but it has been shown that when we do that, actually a lot of the concentrate is consisting of blood and fat rather than true stem cells. So does the BMAC actually work for osteoarthritis? Again, lack of high quality evidence and varying degrees of beneficial results. And so it is really very hard to conclude at this point in time whether the stem cells do give an additional benefit over PRP itself. So one of the things that we actually do in Singapore is that we actually also look at whether the cartilage defects are generalized or focal in nature. So focal defects are typically seen in younger patients, and this can be traumatic or even after avascular necrosis or even in early arthritis. So that is why on top of the drive towards autobiologics, we are also starting to use scaffold-based techniques. And the whole idea is to kind of mimic the super clot that we want in the knee itself. So the question that we ask ourselves is, are we able to deliver this PRP or stem cells to a region that needs it, rather than just injecting into the joint, and it could still be lost to other things such as effusion or even inflammation can actually wash away the goodies that we're trying to give. So traditional methods involve using microfracture, where we actually puncture the bone itself, and that's sort of thought to allow the stem cells to leak from the bone into the joint, but that has actually been shown to be not as good in bigger lesions. So nowadays we tend to use a collagen scaffold, and this can take place in the form of an injectable or a patch that we can put on top of the knee itself. So we clean up the joint surfaces and we dry the joint surface, and thereafter we actually apply the collagen scaffold. And some of these collagen scaffolds are actually compatible with PRP and VNSC. That is to say, if the surgeon so wishes, he can actually augment his scaffold with PRP and stem cells itself. We then contour the gel itself, hoping to form this very stable scaffold and delivering the orthobiologics at maximum concentration to the area where it's most required. So what are our local results? So this is a paper by Prof. Andrew. Basically, we looked at 22 consecutive patients, the scaffold that I talked about with microfracture versus just microfracture alone. And although both groups had improved results at the end of 6 months and 24 months, but the group that had actually scaffold actually shows that they do well even on the scores of the MCS, the mental component, as well as the IKDC scores as well. So while these are very early results, but I think it is enough to show that when we actually try to hold the PRP and stem cells in the area using a scaffold, it can actually work better than just giving the injectable by itself. So in an evolution of the technique as well, there are solid scaffolds that we can use. And what we do is that we actually trim the scaffold to match the defect that we are looking at. And this matrix can then be covered up with a combination of an injectable scaffold or even with PRP and VMAC itself. Thank you. Oh, sorry. Not yet. So last slide. Sorry. So what are the results from this? So this is a paper from overseas, and basically they look at 21 patients, and they find that in terms of using a scaffold, it is still very good method to treat lesions that are very big. So it might not be worth the effort for a small lesion, but definitely something to consider in the big lesions. Thank you.